Oh, yeah. Oh, okay. Okay, I think I'm live. It's happening. I don't know if I got like light on my face, but it's alright. So, I don't know how the sound's going to be. I don't know how the sound's going to be. Maybe someone can leave a comment if the sound's not good. I think I fiddled with stuff, tried to do some fixing. Maybe the sound's better. I don't know. If the sound is bad, leave a comment. Let me know the sound is bad. Oh, I got a text. Oh, my baby's down already. Hold on. All right. All right. Okay. All right, here we go. Cath Lab 101. Cath Lab Nursing 101. What is Cath Lab Nursing? Cath Lab Nursing, essentially, depending on the setting, is circulating, meaning guy in the background or girl in the background. Guy in the background, girl in the background. Giving medications, fetching Lord knows what for the doctor and the scrub, and basically managing the safety of the patient during the procedure. So, some cath labs have anesthesia, like cardiac anesthesia. Some don't. So my cath lab doesn't really have cardiac anesthesia. If the doctor, for some reason, wants anesthesia, say the person does not respond well to moderate sedation, fentanyl versed, we'll call it just a general anesthesiologist. They'll come down, they'll give them a very light propofol infusion. Rarely would they intubate somebody on the cath lab table unless, they were losing their airway and crashing. That doesn't usually happen when anesthesia is there. Anesthesia is there usually just to give some propofol instead of fentanyl versed. So the nurse generally is giving fentanyl versed. They are managing the airway, monitoring the blood pressure and the breathing, ABCs, monitoring and managing their anticoagulation. Because in the cath lab, when we're sticking tubes down into people's hearts, those tubes are made of like plastic and metal. Some of them are coated with stuff, but on the whole, the metal and the plastic can, aggregate clots. It can make clots on the plastic or the metal. So we don't want that. That's not good. That's bad business. So we give heparin or Angiomax. Generally, those are the two medications. So you'll manage their anticoagulation. You give heparin or you give Angiomax, two different drugs, and you monitor their anticoagulation as the circulator. And you fetch stuff. You put drugs on the table. If the sterile table needs drugs, you give them, lidocaine or nitro or adenosine or verapamil or cardizem or, whatever they want on the table to push intracoronary or intra-arterial. So you'll sterilely drop that. You'll help prep the patient. Put the EKG on, put on the oxygen, shave the area we're going to access. The wrist or the groin. Shave the area, clean it, scrub it. Prep the patient on the table. You'll kind of recover them, make sure they're awake afterwards. Some cath labs will do pre-op as well. So, for instance, oh man, look at his hair. I see myself in the mirror. I gotta do something about this. Living like a homeless man. Anyways, some cath labs will have the circulating nurse who's going to be medicating the patient do a pre-op assessment. They'll get an IV or two on them. They'll give them some fluids. They'll do a 12-lead EKG. They'll do a med reconciliation, make sure they took the medicines they're supposed to and stopped the medicines they were supposed to. And they'll do like a head-to-toe assessment, just a basic pre-operative admission assessment, right? Do all that stuff. Some of the nurses, and then after you do your pre-op assessment, they're all ready. They're in their gown and they peed and whatever. You drew blood, and you have the IV and all that stuff, and you feel comfortable taking them back. Then you take them back to the cath lab, and then you continue the procedure. Sometimes, and then when they're done, you'll take them back to their room, and they'll recover right. You'll wake them up, make sure they're not having chest pain or any problems, they're bleeding at their access site, and then you send them home or whatever, or send them to the floor. Some cath labs have you pre-op, have them recover, and you do the intra-procedural, job. My cath lab, we don't do that. Okay. I don't know how to change the bit rate. I don't know what that means. Whatever. So that's what it says. Someone says audio streams current bit rate is 0, and it's lower than the recommended bit rate. We recommend that you use audio stream bit rate of 128. Okay, how do I do that? See if I can do that. Settings, audio, bit rate. Is there a bit rate? Look at this. I'm ruining my. This is not produced. You know what I mean? This is not sample rate. Okay, whatever. It doesn't matter. I don't have any plan when I do this stuff. I don't have any plan when I do this. I just come on here, start talking, stream of consciousness. So get what you get, right? Try and give as much information as I have. So another thing that you learn as a cath lab nurse is cardiogenic shock management and resuscitation. So you'll learn how to use the intra-aortic balloon pump. You'll learn how to use the Impella 2.5 or CP or RP. If you got cardiothoracic surgeons, they'll use a 5.0. We don't have a hybrid room with cardiothoracic surgeons, so we don't have that. I'm just giving you my experience, right? There's other places that do way more than I do, so they know more stuff and other stuff. But I'll just give you what I know, okay? This is just the basics. So you learn how to set up the Impella, learn how to set up all the, the intra-aortic balloon pump. You just learn how to set up the imaging. So you have like Philips makes IVUS, intravascular ultrasound, and St. Jude makes OCT, which is optical coherence tomography. So those are big machine things that can measure, vessel size, lumen size. They can show what the plaque or the lesions are made of. Is it calcium or, fatty plaques or thrombus? It'll show what it's made of. It'll show, side branches. OCT will show side branches with 3D imaging of the vessel. So you learn how to use all that crap. So you'll be setting it up and doing that stuff. That's basically what the nurse does. The nurse is the facilitator of the lab and make sure everything, patient stays alive, patient stays comfortable. The doctor has what he has, what he needs. You fetch wires and catheters and, basically wires, catheters, and balloons and stents. Wires, catheters, balloons, and stents. Wires, catheters, balloons, and stents. All kinds of crap. You just keep, and like other crap that they need. You learn all the stuff that you might need to put on the table that they're using. You can also, you also help set up ultrasound if they're getting ultrasound to get access. You'll set up the endoflator. You'll help the doctor set up the endoflator, or the scrub tech. So this is like, that's like what you do as like the circulator nurse. And if you're lucky, if you've been blessed with an amazing Cath Lab management, you may have a 4-man crew instead of a 3-man crew. And so with a 4-man crew, you have the circulator, you have the scrub tech, you have the monitor tech, and then you have the backup circulator. So the backup circulator is like the fetch it guy. He's going to get all the stuff. He's going to do the ACT, the activated clotting time, and the iStat little machine that checks you put the blood in the machine gives you a little number, and you can see how anticoagulated the patient is. So, you have a backup circulator. They're going to be doing a lot of that stuff, fetching stuff. So then if you're the primary circulator, you're just doing hemodynamics, moderate sedation, airway management, that kind of stuff. So one of those 2 jobs, that's what the nurse does in the Cath Lab. That's like the nurse role. But, like our Cath Lab, the nurses will also do the scrub role. So after you do the circulating role, you do the scrub role or the monitoring role. So you use the computer and you document everything, you chart everything. Because in the lab, in our lab, the nurse isn't charting while they're working. It would be a bummer if you had to do that, because a lot of things happen really fast. You feel to do a lot of fast stuff. Now while you're doing all that fast stuff and focusing like kind of intensely on the case, you don't want to have to be like documenting while you're focusing. It just takes you away from something that could happen. So you have this monitor who's documenting everything. So you just say out loud, I gave 1 of Versed and 50 of fentanyl. 1 in 50, you make sure they hear you. Boop, boop, boop. The monitor tech will put it in. Put it 1 in 50 at this time by this guy for this, So, so you might be monitoring. You learn how to monitor, and that how to use all the all the documentation for the case. So you'll document the case, and then you'll scrub the case. And you get sterile, with sterile gloves and a mask and a hat, and sterile gown and all that stuff. And you can get access if your policy allows you to get access with arterial access with ultrasound. You get venous access with the ultrasound. You put the sheath in. You get the cocktail. You give a big cocktail in the artery to prevent vasospasm when you're going up with catheters. So, you do that as the scrub, so scrub tech or nurse, or I don't know, whatever. So the nurse can scrub too, and you put in the wires, you put in the catheters, you use the endoflator, which is the little thing that you twist and increases atmospheres and increases the balloon angioplasties, the coronary arteries. So you get to do that. Deploying stents and all that stuff. And, there's a lot of other stuff you do in the Cath Lab. We don't just do hearts. Like our Cath Lab, we do interventional radiology stuff too. Some interventional radiology, but in ports and tunnel picks and nephrostomy tubes and all kinds of crap. So you might end up learning, doing that stuff too, IR stuff. So you get cross-trained in IR, interventional radiology. It's the same concept. You get the stuff they need, manage the airway, manage the hemodynamics and the sedation, make sure the patient's safe. That's it. That's what you do. It's not super crazy. It can get super crazy. It can get super crazy, but it's like pretty straightforward. Like, keep the patient alive. Do whatever you have to, safely, and be diligent to keep the patient alive. And as long as they're not in cardiogenic shock, it's generally pretty doable. Even if they're in cardiogenic shock, you can still do it. I mean, it's just A lot of times we'll get them through the case. People with cardiac shock, they don't usually die, knock on wood, they don't usually die on the table. But if they're really sick, their heart doesn't recover, and then they die in ICU later after the procedure. So usually we'll get them through the procedure if they're not already dead before they came to us. That happens sometimes. Where we're like doing CPR in the ER, and they're intubated and doing CPR in the ER. We're shocking the ER, and we're doing compressions into the cath lab. That's not, pretty low chance of a good outcome at that point. But you give your best try. You try your best. You just go for it. You just kind of do your best, and that's pretty much it. That's pretty much it. There's not a whole much more than that, I think. There's more stuff, I'm sure, but maybe I'm just tired. I think I'm tired. So you gave 15 minutes. I like 16 minutes. I like that amount of time. I think that's a good amount of time. So if you made it this far, I thank you. This is great. I feel like, a lot of talking was done. I'm a little tired. I'm on call right now. Could get a call any minute for a STEMI or something, which is that's always fun. You just never know what you're going to get. I love that. Yeah, we're at 16 minutes. Already at 16 and a half minutes. Man, time is just flying. All right, that's it. If you made this far, excellent. If you have thoughts or opinions, comments, questions, concerns, feel free to make them known to me. I'll respond back if you want me to, gladly. Very interested in anyone's opinion as to what I had to say. If you have ideas that you would like me to expound upon, feel free to comment or make those known to me. All right.